most people on Earth, planet Earth, do not like their jobs and do not like their
Yeah.
work.
The medical error is the third largest cause of death after cardiac arrest and cancer in US. Today we are joined by Dr. Charlotte Blees. She is the author of the book Dr. Bot. In this book, she explores a very interesting perspective of how artificial intelligence can be integrated into the field of medicine. And most interesting part is that what are the ethical, practical and human challenges that come with it. How we can actually explore the potential of artificial intelligence into the fields like clinical decision making and make patient care more proficient and more advanced. So in today's conversation, we are going to dive deep into the question that how artificial intelligence can be integrated into a field like medicine and what it means for patients, what it means for the doctors, and how we have to be cautious while the technology continues to evolve. So I hope you're gonna enjoy it. So let's go. Thank you so much, first of all, for joining me and taking out the time from your schedule to have this podcast with me.
Delighted to
And
be here.
your book, Dr. Bot, is already having so much of a fan base that I have seen and I have heard your talks. And truly, it's a fan moment for me to have you here, uh,
Oh,
talking
that's
to us
lovely.
here.
It's very kind of you.
Okay, so actually, I would like to start this podcast by the line you mentioned in your book that the medical error is the third largest cause of death after cardiac arrest and cancer in US.
Yes. So this has actually been a very debated finding, and there's been a lot of pushback in the medical community in respect of this finding. But also, as I'll say that caveat it by saying it's had pushback, but what we're looking at is considerable. I stand by it actually. And I've dived into the literature and I've taken a deep dive into that. But the issue is this is a very understudied area. As I say in the next chapter of the book, that in itself is very interesting and tells us something about how seriously the medical community over the decades has taken human fallibility. But we need to take it a great deal more seriously. So the fact of the matter is, a lot of patients could be harmed or may have died who are not being reported. So we can push back against the naysayers who have in some respects conflict of interest here in which it often doesn't get stated in medicine, in not drawing serious attention to human fallibility. So it's a real entanglement of issues, but yes, there's considerable harm and yes, mortality as a result of largely miscommunication in medicine, but a whole range of other issues, including misdiagnosis.
So, also you mentioned something about known as the defensive medicine that is being
Yes.
practiced now. So, does that impact how we adapt into new technologies in the area of medicine, and does it have a pushback from the people in the area itself because of their having this practice without even knowing they are doing it?
Yes, so I think that there's a kind of defensiveness within healthcare because people undergo a really long training, and that means that they have a certain attachment and allegiance to what they do. And anybody who's undergone a long training does not want to give it up because it's a core part of their professional identity. So when you see these new tools emerging, it can be very nerve-wracking. It can be scary for doctors that their core clinical tasks may be threatened. So I think we're witnessing something like an identity crisis in
Okay.
healthcare, but I also think that in general there can be, as I say, in any field where you've been trained and you've had a long investment in time. But also, I think it's important to remember that, look, healthcare professionals, particularly doctors, have a high status position in society. So you've got
Yeah.
not only the education, but you've got prestige, You've got a pretty healthy remuneration through the job. The fact of the matter is, not most people on Earth, planet Earth, do not like their jobs and do not like their
Yeah.
work. But for a certain stratum of society who is well paid and for whom work derives a lot of meaning, um,
Mm.
this will be. That's not to say medicine is easy. It is not easy, but um, it's rather a lot to think you could give up in the face of competition that doesn't look like you.
And like we're talking about a field like medicine where we already have like shortage of people, because we know that we when we go to the doctors we have to wait like 3-4 months for like getting an appointment, specifically in Europe, and I think that US has the same thing over there. So we're in such a competition, and with this defensive attitude and also with this conservative attitude, where are we heading in medicine exactly now? This is like we have lost our way, because the medicine means to help people, I think, and now, I mean, it's just the opposite. It's troubling people somehow.
It's really interesting because I still think, doctors are doing an amazing job. Our health systems, yes, there are many compromising factors depending on where you access healthcare in the world. But I think that we definitely are at a kind of fluctuation period with the professions, where their identity of what a doctor does is shifting a bit, and that's inevitable. Um, but I think it will take many, many decades for AI to fully disrupt healthcare. We're already seeing that people use these tools. So patients are
Yeah,
using these tools to decide when to go to the doctor. They're using these tools to work out what might be wrong with them. Um, they're using them almost as a first triage system. So what I suspect will end up happening is big tech is really entering this space. And I suspect what we're going to have is a whole plurality of health systems and ways in which people are going to access expertise. People are already doing it, as you say, where they
yeah,
can't get access. Um,
yeah,
and also, I think we're going to see more disruption in how care is delivered again through private enterprise. And
yeah.
I think ultimately patients will vote with their feet. They'll do what's most convenient and what serves their interests well.
Yeah. And like you mentioned about the artificial intelligence and the integration of it in the medicine. Now we know that right now what artificial intelligence technologies we have, they're not very much perfect. They have hallucinations, they can make up references, and they can make up stuff which does not exist in reality. So when humans are also making errors and machines are also, at least as of now, they're inevitable to make errors, then how will this integration actually help the humans?
It's such an interesting question. So this is where it's really important to think about the psychology and the relationship between the human worker and the AI system. How do people respond to algorithmic output? And um, what's really interesting here is there is a large body of research that has often been siloed from healthcare, and I discuss it in the book, chapter 9 in the book, where I discuss how actually people who are domain experts. So if you're an expert in a particular area, you're less likely to take algorithmic output seriously. We've known this for
Yeah,
decades. And indeed, what we've seen with some very recent studies is that when you pair doctors with generative AI tools, they tend to hurt the accuracy of the AI. So we've got this
okay.
interesting, so if you leave the AI alone in these are of course experimental setups, and as you
Yeah,
say, everything is true. We still need way more real world patient evidence, but um, it's still fascinating to see that in some areas doctors will be too, if you like, nose holding towards the algorithmic output, hurting its accuracy in certain contexts. whereas lay people for whom this isn't their expertise tend to be more deferential. They tend to trust the AI more. But in other contexts, I think we're going to see an emergence of, and I think we already do see it a bit anecdotally as well, where, for example, doctors don't like doing documentation. It takes up about
Yeah.
50% of their day. So in those sorts of contexts where you've got what's called ambient AI, and this is where the AI listens to the medical appointment. So it translates what's said, converts it into documentation in an electronic health record,
Yeah.
and then the doctor can, or healthcare professional can check over what's written. And what may be happening is, and in those contexts they also see errors. The AI is not
Mhm.
perfect, it can make stuff up. But then again, as you've pointed out and as I've said in the book, doctors make a lot of errors in documentation. Sometimes they're
Mhm.
writing documentation on the weekend after they've, which is, not great
Yeah.
when the doctor's handwriting is notoriously bad as well. So about 1 in 5 people see errors in their notes, and about 40% of those are quite serious. So you've got, but when you have this ambient AI, what may be happening is doctors just trust it, and
Yeah.
they defer to it, and they may not be correct. I've heard from other colleagues, and we don't have still the number of studies, I think, properly at scale on this. But it may be doctors are too deferential, too trusting of AI in some contexts. So
Yeah.
you're absolutely spot on. We've got this odd relationship that we've got to be more nuanced about how people, including how their expertise, how they've been
Yeah.
trained, how alert they are, and how well they work with technology. It's sometimes called the last mile problem in healthcare. How do you actually
Yeah.
get people to use these tools effectively?
Yeah. So I also have actually your answer actually led me to two questions that I have now. So I will go with the first one that is my favorite question. Basically, like the nature of biology is very complex, right? So the research in biology is never ending. There are so many perspectives to one problem itself. So how do I know that artificial intelligence, while fetching the data, like you mentioned in your book, that an article is published every 40 seconds, so it's impossible for a doctor to be updated with everything, and there the role of artificial intelligence comes in, right? So I'm actually very curious to know that how do I know that artificial intelligence is processing the data in a way that it understands the nature of the biology, and it is not just taking in the data and spitting out the facts without making any relation to the current subject. So how do we approach that problem?
That's it's a kind of a really basic problem to do with the architectures of current AI. And as you say, they tend to be uh there tend to be probabilistic devices. So they're not really engineered to seek the truth. They're very good at seeing connections and relationships in the data. So then, but these tools are. It's likely that newer architectures will get better and start to, if you like, think. Well, it's thinking in a different way. How do we get closer to understanding causal relationships
Yeah.
and so on, and have something more closely aligned with what scientists want to do? But these tools, of course, are that's still a very useful business in science. Um,
Yeah.
so, and of course, we've got Nobel Prizes on the basis of what AI
Yes.
can do. So, they're very useful
Yogi. Yeah.
they're very useful in assisting scientists in so many ways.
Yeah.
Even when it comes, I mean, people are using these tools in ways that can expedite their research at every level. So
Yes.
the summarization of content, again, if you consider what people were doing, and still may be doing on their own, it would be romanticizing to say that it's always superior, because even if you take something simple like summarizing information across a whole range of articles, that can be very difficult to do well without human error. And of course, we've always relied on artifacts, scaffolding in our environments, whether it's pen and paper, Word documents, and create, or all sorts of devices that support what we counterintuitive thinking, which is what science is, and AI is part of that process. Will it completely take over science? Um, that's not an area of my expertise, but I think it will be very. I think into the future, it'll be hard to do science without these tools.
I mean, yeah, because in the today's scenario as well, when we are doing research, it's kind of these tools comes in very handy for the task we don't want to spend time on.
Yes.
So right now they are behave. I mean, right now I would say they are behaving as assistants,
Yep.
but I don't know in future if they will be like partners or what will be the scenario.
Yeah, and I think it's depending on the context right now, they can function as partners. Um, when people are even doing writing, I mean, I've recognized it myself when people write emails, everybody's emails suddenly became very good around 2023, people who can
Yeah.
string. So you've got an issue where people are partnering in those sorts of tasks, and it can make what's good writing a lot better. If it's not used well, it can be very obvious that somebody has just simply used the tool, and they've not used it with any critical facility, and that can be very irritating too. So I think most people who have experience with these tools recognize that they can be used in very poor ways, um, where you would rather somebody just put the work in, and in other ways, when they're used very effectively, they're great. They improve efficiency and communication and all kinds of things.
Yeah, I mean, they are great tools for learning for myself. I have learned so many things using artificial intelligence. So, yeah, like I'm all for using AI until and unless it's giving the correct resources and is not hallucinating.
Yes.
And I have one more question that actually is a question that I have to ask because I'm a researcher myself. So I know that there is a very big gap between the research and the translation of research. Probably take
Yeah.
years and years to translate.
Yeah.
Some of the very good research is just gathering dust in the archives in our library or somewhere. So how does the integration of artificial intelligence will speed up this translation? Because we all know that times like COVID, we really needed an antibody, we really needed a vaccine. So how will this artificial intelligence integration will prepare us for the times like that?
Yeah, I mean, when it comes to, this is something I did discuss, is when it comes to moving from bench, if you like, to practice. There's a really nice article that was published a number of years ago, but it said, the answer is 17 years. What is the question? And the question is exactly that, how long it takes to move from research bench to practice. Now, in healthcare, you've got this really interesting um, time lag. I say it's interesting, but it's not interesting if you're a patient and you're the recipient of inferior care,
Yeah.
because it's really hard for doctors to recalibrate their medical education when they're working on the job. Um, because that's because of well, they're working hard, but when you commit a body of knowledge, when human doctors learn, they are not only learning um uh in a way that is, it takes I talk about purposive practice basically. So
Yeah.
you've to learn a body of knowledge in a way, but you also have to translate that into how you actually practice, and that takes a lot of time. And it requires feedback as well when you've
Yeah.
got things right or wrong. And doctors sometimes lack that feedback loop. So it takes practice, and it takes considerable amount of effort. So that's why it's often said, and Dave Sackett was a Canadian who was regarded as the father of evidence-based medicine, and he talked about how doctors' education is often fixed at the time at which they graduate, and around that, and by the time doctors graduate, he also famously said 50% of what they learnt is out of date, but they won't know which half. So you still actually have these studies that have been done which demonstrate that doctors practice evidence-based medicine about half the time. That varies between specialty and it varies between where doctors practice in the world. But it's sort of an indictment of how of human expertise on some level. It's really challenging to keep up to date. Even if you've read an article, that doesn't mean you've committed it to memory or that you've incorporated it into your practice. So huge challenges, and this is where AI, even though it has faults, and even though it can hallucinate them, and that's getting that's reducing as well. You have opportunities here to update, and you have opportunities even in using it as a dialogue, which we can get into. Doctors are using these tools and that for that purpose too. So just as patients likely are, though we don't have enough studies. So you've got this interesting area where AI could be, as you said, that you can publish something and it updates incredibly quickly. Um, and doctors just they lack that facility. And this is where we've
Yeah.
got to take AI really quite seriously.
Yeah. I mean, I agree with that, but also then I would think about something called as bias, because you also talk about in your book about the topic of bias, right? That now all these artificial
Yeah.
intelligence models that we are training or will be coming up in future will be trained on ages of data. Even the research that we are doing and the papers we are publishing, it is all based upon some kind of data which is some or the other way biased, because either they represent the global of they represent a very small section of the population of the world, either from US, China, India, or maybe it might be diverse, but it is not definitely equally distributed. Then you gave a very good example that I would totally agree with, what was called that even in our books, textbooks, we have male anatomical figures, and that's why many of the female diseases go undiagnosed. That's why. So when we are training such big models on the data which is already biased, so how do I know that humans, yeah, our minds are biased in one or the other way towards one or the other thing, but when I'm training the AI on the same kind of biased data, so how will that help us?
It's a great question. So as you say, there are biases and omissions throughout medical history. Uh, Even up into how people are trained today. Take even
Yeah.
older patients. That's another area. Not gender is an issue where there's been a bias towards male anatomy as the norm, but older patients tend also to be left out of the equation too. We tend to think of test our treatments on um, adults who, up until the age of around 50 years old. It gets more complicated to do studies on older people too. So we have these deficits within medical knowledge and understanding. We have bias in how research is conducted. So as I said, some populations are easier to study. We have bias in terms of where studies have been conducted in the world. Now, how do we redress this? So it's the epithet in AI, and it's something that's been discussed since Cathy O'Neill, Weapons of Mass Destruction. We shouldn't assume algorithms are neutral. You've got this issue, this epithet of garbage in, garbage out. You can end up perpetuating the same biases through technology. They might even be made worse. Um, Partly because people think that technology isn't susceptible to these things. So this is where it's really important to have a keen eye on data processing, data curation, um, and at the back end, that's why we need more people in healthcare considering careers, looking at how we can improve the data, how we can improve and test in ways the the AI to make sure that it is valid and it is trained in ways that are accurate for new populations of people. So one aspect of it is considering that as an actual role in itself, and a job that is taken
Yeah.
very seriously in healthcare. But the second aspect of it too is also to consider, look, we are focusing, and it's related very much. There has been a focus in AI ethics on bias, for very
Yeah.
good reason. But we've also got to consider, as you've said, that sort of the argument shouldn't stop there, and that's for two other reasons. First of all, as you've said, and as I talk about at length in the book, human beings are biased. So
Yeah.
if we just simply depend on what we've got, you're not solving the problem. It's not enough to say AI's biased, that's the end of the conversation, don't use it, because you're still relying on human beings who make quick and
Correct.
dirty biases. And that doesn't help patients ultimately. And then the second reason is that leveraging AI to improve, to reduce biases is also, or to use it to identify biases is also really valuable as well. So I mentioned a researcher at Cornell called Emma Pearson, who's a computer scientist, and she did a review of studies, and she found about 85% of studies that looked at large language model AI and bias considered the harms, but only 15% considered there's actually opportunities here.
Yeah.
And I'll give an example of what opportunities could look like. If you look at the electronic health record, so in a lot of rich countries, not all, you've got electronic health records, and what you can use in this case, natural language processing. You can look at scale, and you can look at people's electronic health records, and you can see patterns according to
Yeah.
demographic details or conditions of how the notes are written. And you get real insight by using this technology that would take human beings years to sift through. You can
True.
see very rapidly whether there are more negative descriptors in notes about people with addiction disorders, or pain, all kinds of chronic pain conditions as well, interestingly. So you can use AI tools to hold a spotlight on human behavior as well. Another opportunity, in fact, one Emma Pearson discussed is, because AI can see things we can't see, but
Yeah.
sometimes we don't know how it does it. Sometimes as humans, we don't know how we do things either, and we call it
Exactly.
art. But so she looked at X-rays in osteoarthritis, and the algorithm was able to predict 5 times more pain for patients on the basis of x-rays who were low income or African American. This was a study in the
Oh,
States. And radiologists were not able to predict on the basis of x-rays. They couldn't see it. Now, that's really critically important for
yeah.
patients who are suffering. So there are opportunities here. There's also, as you've said, and there's a rich debate and discussion about it, massive risks with AI as well, for bias and for worsening inequality in society. And that's also something that needs to continue to be discussed. um, Even aside from what the technology can do, you've got issues that not everybody has um, internet-enabled phones still, although
Yeah.
that's improving. But not, people can suffer from data poverty even if they have AI, even if they have a digital device. Um, so there's a whole variety, and then you've got the issue of what happens to people's jobs in healthcare if things are,
Exactly.
and so you've got a whole variety of considerations here. Who gets to own healthcare systems in the future? And
True.
already we're seeing, OpenAI said in October 1.22 million people every week disclose to ChatGPT that they're suicidal. That's
Yeah.
sensitive information that these tech companies have about us at our most vulnerable states. What's happening with that information?
Yeah.
So, and how does it? What are the consequences for our life? And if you're a young person, you're disclosing this, it's going to follow you around for the rest of your life. So there's
Yeah.
huge issues here as well with embedding biases, worsening opportunities for people. But there are opportunities. These are political issues and ethical issues
Yeah.
that need to continue to be discussed.
And like you mentioned about in detail about the biases, so I will have like
Yeah.
a question over here. So earlier in the conversation, you mentioned that already the system is overwhelmed. Doctors are depressed and they are burnt out. And like when I give them the tool like artificial intelligence in their hands, right? So the already burnt out and already overwhelmed doctors, when have such a tool in their hand, will that add another layer of pressure and another layer of bias? And that may be what you said is leading to overriding AI, because now they are also competitive and they want to be just better than a technology that they have as a collaborator.
Yeah, so it's so I would say in response that couple of things. I think it depends on the context in which they're using these tools and what they're using them for. So I've I've conducted studies for about nearly 10 years on doctors' attitudes towards technology and what they think technology will be good for. And overwhelmingly, doctors think technology will be good for documentation. So, and they've thought this for you because it's very consistent. Um, so part of that may be wishful thinking as well, because that's the thing they absolutely hate is administrative tasks and documentation. So you have this aspect of an attitude that they may be more deferential, they may be more inclined to use it for documentation, and we are seeing increasing uptake with ambient AI.
Yeah.
Um, so you have that side of things, and however, where doctors may be uh, increasingly nervous, is that when the ambient AI begins to, and you've got future systems that are beginning to suggest differential diagnoses based on what they've heard and combining
Yeah.
that with the electronic health record and the patient's history, and that's what's inevitably going to happen, especially when you combine it with a whole range of test results and other kinds of sort of combine different modes of information. AI will get very staggeringly accurate. Um, so I guess the issue is, as you said, like, is this going to increase burnout? Look, if a doctor uses ambient AI, and we've done studies on this too, what seems really clear is that doctors actually have reduced feelings of burnout, because these tools take off that burden. But what's also interesting is it's not quite clear whether it actually reduces the time spent. So these tools were sold as they're going to improve efficiencies in care, but there's a lot of question marks over whether that actually happens. Um, Yet doctors feel less burdened when they use these tools. And that may be because, like, it's really hard to start writing a note yourself.
Yeah.
It's a task that you know is an added layer of stress and pressure. Whereas if you have it in front of you and you can edit it, you already feel, part of the burden, and the stress is taken out of it. Um, but in general, what we found in our surveys is, and as you say, previous, like, AI has been in medicine for decades,
Yeah.
in clinical decision support tools, sort of expert AI. Um, but these tools were good, what was called good old fashioned AI. But these tools had very poor uptake. And they were regarded, as you say, as they created fatigue, and they might have given flagged up, don't prescribe this medication with that one, or have you checked the patient for this, that, and the other. And doctors end up overriding those alerts. They just were too. They were like noise in a visit, like literally interfering with creating more multitasking and challenges. So there was never great evidence that those sorts of AI were very effective. Um, and what's different then about generative AI tools is they are like a dialogue. So it's less a case of this AI spitting out and interfering with you. It's not responsive to what you're doing. These later generative AI tools are a bit like talking to the internet on steroids, as anyone who's used them can recognize. And you can control the conversation. It's like having another agent in the visit. So what we found in our surveys, and people, this was 2024, we surveyed uh, British GPs, and we found, and this was we were surprised by this. So about 1 year after ChatGPT was unleashed, we found that 20% of British GPs said they were using tools like ChatGPT for clinical tasks. And we did the survey. It was just published about 2 weeks ago. We redid the survey a year later, 2025. A quarter of them said they were. So that's a massive uptake. By the way,
Yeah.
the vast majority, 95%, said they'd no training. So nobody was telling them to use these tools, but also nobody was clearly saying don't use these tools. So you had this
Mm.
migration, just like the population at large. People are using these tools. They're deriving some benefit. Um, and doctors said they were using them for a variety of tasks. So the AI is different now. And it's likely that they won't perceive it as a burden in that sense, because it is like an agent. It's like almost like this secret person, and
Yeah.
people are sometimes very reticent to say they're using these tools. Um, they're using them surreptitiously, as they are. I colleagues are probably doing the same. Nobody wants to own up that they've got this sort of secret friend that they
Yeah.
consult with and ask things of. But they're using them. So I suspect this is a different scenario now with these kinds of
Yeah.
technologies.
Do you think that this kind of, I would say, this kind of approach that we use AI, we want to use AI, but you don't want to tell people that we are using it, is the reason that why, first of all, doctors do not accept when they are using AI or do not want to accept? Also, this is one of the reasons that why they are actually resistant to sharing the access of the medical records of the patients with them, because they think that they will use AI and they will reduce the consultation and will might be reducing their income or affecting the number of patients they have. So do you think this is one of the reasons?
Um, I don't think it's one of the reasons why they might resist patients accessing the records. I think in that case, there's so if you take record access, and it differs in different countries, but what's been really fascinating is, in general, doctors don't like patients poking their noses into the records. And there might be there seems to be a variety of reasons for that. First of all, doctors sort of feel like they own the records, they wrote the records. But they also worry about the patients reading records and then adding to their burdens. Patients see a test result or
True.
they read something, they don't understand it, and that will create more burdens on the system. But I think in general, there's a certain guardedness as well in the professions. Um, and Richard and Daniel Suskind have written a lot about this, but also sociologists have discussed this. Um, the professions in various guises tend to guard their expertise quite jealously. They tend to ring fence it, because in a certain way, what you've got is a sort of contractual relationship between the people who use services and the professions. And the professions tend to be, including the medical profession, tend to be self-regulating, but they also have a great deal of power. So you do
Yeah.
have this perpetuation of status, power, you've got concentration of expertise. And in that scenario, I mean, people who have been trained in a particular way or member of a profession want to maintain that. Um, and it takes on its own momentum in some sense. So things that threaten that expertise, such as somebody gaining access to how you do things, how the professions think in a certain sense, can be perceived as threatening. And So that's been an ongoing issue, I think, with online record access, and the idea that you're seeing something that could end up challenging what the professions are doing. Certainly, AI may be used in that sense. So not only could AI end up taking over, as I say, some of doctors' expertise and how
Mm-hmm.
core clinical tasks, but it can also be used to challenge. And I think we're going to get more interesting medical legal cases where if the AI is used to suggest where doctors have done the wrong thing, or
Yeah,
uh, lawyers and patients can see that, well, the patient clearly had this, but you made this diagnostic
yeah,
inference that that was incorrect, or you should have followed a different standard of care. Um, so, so we're going to get cases like that. But yeah, I think there's a nervousness around the professions for that reason, and you know it's affecting all kinds of lines of work as well. And we've got this interesting scenario where white collar workers have always felt more protected from
yeah,
disruption when it comes to occupations, but it's happened in other lines of work. The assembly line worker in the factory who loses their job. A whole variety of lines of work are affected by technology, and this time what's different is it's come for cognate fields, so fields that rely on reasoning, thinking, a level of knowledge. That this is what's different this time. And eventually, if you like, some of these jobs, and we're seeing what economists saying, are not going to be coming back. And that
yeah.
leads us to ask really very demanding questions about how society functions, what do we do with mass unemployment, very urgent questions of economics and societal organization.
I I mean, yeah. I mean, it brings me back to the question that I mean, the medical community or the doctors, they want to play defensive, like they don't want to lose their jobs or they want to loosen their status of because they enjoy a status in the society which is like at the highest because which also brings them to a lot of pressure because they are considered next to God at in most of the societies because they are the lifesavers. But
Yes.
you mentioned in one of your talks that sometimes they are screening the patients so much for cancers that actually they develop cancers as a result of so much screening. So, I mean, this is very ironical that they don't want patients to just come to them for everything, but also they are screening them so much. So, what's the reason of this kind of behavior? Like, I don't understand. Like, they don't want patients to bucker them every time, but also repetitive screening even when nothing is coming up. So, why such a
Yeah.
disparity?
So we do have a lot of interlocking interests in healthcare. You have big pharma that has a self-interested reason in over treating patients and selling medications. Um, and in healthcare, depending on the system that you work in, patients can be, either billed for not only the time, conditions, and all the rest of it. So you do have all of these interlocking interests. You've also got interlocking interests with licensure, which can mean that in some countries there's expanding licensure, for example, across, like in the US, across the states into different states, means that there can be a loss of income in that state. So you've got lots of, which was one reason also why telemedicine was resisted for many years as well. Um, so you have issues about how you license doctors, the money that's gained from that. You have issues of big pharma. And we're going to have, of course, new interests with
Yeah.
technology as well, and the potential there for advertising when people are disclosing their medical information and further exploitation. So there's a vast number of these conflicts of interest that arise. One of the
Yeah.
things I mentioned in the book is it tends to be more obvious to people that big tech is a threat. It can be exploitative.
Mm.
Um, I give the example of lobbying in the US. So tech giants, well recognized to
Yeah.
lobby. But actually, the American Medical Association is also one of the top 10 lobbying groups in the United States too. So you've got these very seriously rivaling with the amount of money that they're spending to sway opinion,
Yeah.
political opinion. So it's important to recognize that the professions have a great deal of concentrated power and influence that they will not easily relinquish. Um, and as you've said, there's prestige, status in society that means that people will not particularly want to give up their
True.
job. And that's not just to be out and out cynical about things either, because look, people are working incredibly hard in these jobs as well. Nonetheless, there's sort of, if you like, unintended in many cases. There's benefits to people that should be
True.
openly discussed, and there are conflicts of interest here as well, because ultimately it's an ethical question: who or what could do a better job of
True.
improving patient care? And there's not likely to be a clean answer to that in many scenarios too. There's going
Yeah.
to be potential benefits from some modes of delivery, while there's going to be trade-offs as well, and that might be in terms of privacy, even if you get greater accuracy. Um, so how these systems are regulated is going to be an increasingly important question, and how successful our government regulators are in ensuring that patient care is at a premium, and the benefits to patients are at a premium through these emerging systems is going to be really critical.
I mean, yeah, I mean that's also part of kind of human biases that when humans are in role, a lot of things already comes into play. That's government regulations and that's their benefit. So that's why they collaborate with pharmas. And when you're having the clinical trials, they're a very big part of it. And then the FDA approval. So I think when humans come into play, it's automatic that a bias will come into play, regardless of what kind of patient is being taken care of. And uh, I also want to ask you that in the book you mentioned, and it was very surprising to me, that we as humans are more prone to open ourselves to artificial intelligence, to a bot, than to another human, say doctor, because you told that in the book that a lot of patients just conceal the very critical information from the doctors, which is necessary for treating them. Why do patients do like that, and why do we humans have a tendency to open up to a bot than to a human?
Yeah, it's a fascinating body of research. And I will sort of preface it by saying this is the human connection is the thing that doctors most uh, push back. Whenever you talk about AI, they say, look, but nobody will do human, or nothing can do human connection as well as we can do. And yet there is this body of research that shows actually from whenever patients were first put in front of computers,
Bot.
back in the day, they were monster-sized computers, and they discuss that in the book. Back in the 1960s,
Yeah.
um, patients have opened up with technology. And part of the reason is, again, if you look at the psychology of status and prestige and dominance. So status tends to be differentiated by both sort of prestige. So people tend to defer to people who are prestigious because they have some body of knowledge or something. Um, or because someone's dominant. In other words, they can be they're a bully, and one feels subordinate to them. And what I discuss is actually healthcare is an arena for both kinds of status. Patients, and in both scenarios, patients tend to be uh, subordinate. That is, they tend to be less forthcoming, more anxious about challenging. So people don't tend to challenge somebody who's high in status. They don't.
Yeah.
On the flip side, people who are higher in status tend to interrupt more. They take the floor more,
Yeah.
and subordinates also tend to want to either want to be sort of invisible in this situation, or they want to present the best version of themselves, making it very hard to be completely honest and candid, especially about something that might be socially stigmatized. So you have this body of literature which shows people are, and it doesn't need to be technology, incidentally. If you give people a pen and paper, and you tell them to reveal things, they're going to be more honest than if you sit them in front of
Yeah.
someone, because it's just easier to be more forthcoming when you don't have those social cues in front of you of another human being who you
True.
might maybe intimidated by or worried about their judgment. So you do. So I cite these studies which show that patients are particularly they delay help seeking for mental health conditions, for things
Yeah.
like domestic violence that would be socially stigmatized, but also for embarrassing red flag cancer symptoms too. I mean, I could give you the example of my own father who had bowel cancer, change in his bowel movements, and quite a classic case, delayed seeing the doctor, and when he did, spoke to the doctor about his ingrown toenail, and then at the last minute his hand on the door mentioned, well, there's one more thing. That's a very common scenario.
Yeah.
um and but it risks people's health. So
True.
this is where technology actually could be a real boon. And why it's not
Yeah.
surprising, we've got everybody clutching their pearls, legitimately worried about people pouring their hearts out to machines. But we have known this for many years. It's just that we didn't do anything about it. And I do discuss how some doctors who have used technology to solicit patient information get a much richer patient history as a result of doing that. Um, but again, in our health systems, we've chosen not to do that, which I think was a mistake.
And also, like you mentioned, that there is a disparity in between the kinds of patients we have. So the patients that are higher in status, they'll probably take the floor, and they probably will interrupt or maybe engage more in their own consultation. But with the people which have a low self-esteem, or have some embarrassing issue, they'll probably just not be able to take the floor and
Yeah.
not be that engaging, and probably will conceal the details. So should, I mean, is there a starting point of making this kind of technologies first of all available to the people who really needs it? Because if you have some rich person over there, I'm pretty sure that they would take the floor, because it's sometimes it's all about the power in your pocket. That's how sometimes the system works,
Yeah.
right? So it can be made, starting to be made available to the middle class and to the people that are poor, so that you know because these people are very, no, I mean, these people are the ones who will probably not open up even given a chance.
Yeah, it's a
So
really interesting point. So what you, yeah, so sorry, there's a bit of delay there, but hope I'm not interrupting. But basically,
no,
what you
no,
are
no.
finding is um, yeah, so what we're finding is that, as you say, the research shows that people who are comparatively lower status, so people who are have fewer years of formal education, who have a lower income than their doctor, who don't share the same first language or same skin color, they're less likely to be um, they're more likely to be affected by those uh, power dynamics. They're less likely to be forthcoming. They're going to feel less comfortable in the visit very often, and will be less forthcoming with questions and so on. They're more likely to be engaged in what sociologists call impression management, which can be a real
Okay.
burden in the visit. A bit like in a job interview, you're on your best behavior. You're so self-conscious that you can't engage in the task at hand. So anything that works around that is going to have probably a greater benefit to people who are
Yeah.
more disenfranchised or disadvantaged in a traditional scenario. And what's interesting is if you look at something as simple as online record access. So if you think
Yeah.
about the visit, you might not be concentrating on what the doctor says. You don't want to tell the doctor, I don't understand. But if you get access to your medical records, people who actually read the record and try to understand and what was actually said in the visit or what the doctor recommended, you find in that situation that people who are more disadvantaged actually get way considerably more benefits from accessing their records
True.
than the sort of higher income, better educated patient population. So what I suspect and what interesting, we're seeing some early signals of this. People who use generative AI tools, it's probably going to be the same thing. So they may derive, if you're more disadvantaged, so if you've got a doctor and you feel very comfortable and you get access to it,
Yeah.
you're going to have all the, it might not make as much difference to you than if you have a tool where
True.
you can say, I work a good gig economy job. I have no time to take out to visit a doctor. And I also, when you're there, you might feel disempowered anyway. So this is where you're going to see greater benefits to people.
Yeah.
And there's been a Kaiser Family Foundation survey. So this is a West Coast health system in the US, which found that now the survey's about a year out of date, but it actually found that Hispanic and African American patients said that they found more benefits from using. They found the generative AI tools. They were more likely to consider them to be accurate and trustworthy compared to white Americans, and that might be reflective of the legacy structures in
Yeah.
healthcare, how people access care, the barriers that they face. Um, it just may be people are deriving greater benefit. Similarly, studies with patients with rare diseases, you see households where there's a member of the family with a rare disease are twice as likely to use these tools. Again,
Yeah.
that might be because doctors know less about their condition, and or that they have more visits, more conditions
True.
that they need to keep on top of, and they find these tools just extremely accessible and useful. Um, so there's real potential for benefit there.
Yeah. And okay, so and when we are talking about this integration, this kind of this kind of system where human and AI are working as collaborators and not as competitors. So but nowadays people talk about the two extremes. Either it's like totally it will be in the hands of AI or totally in the hands of humans and AI is all wrong. How do we find the middle ground? Because I have also seen that you mentioned something about this Amara's law, that we as humans have a tendency to underestimate what technology can do in long term and overestimate its short term benefits. So, how do we actually find that middle ground where we can work together?
I think we're already finding it in some sense, but we don't. The debate sometimes, I think, isn't as reflective. This conversation, I think, has been, but much of the debate can, or our instincts when we talk about AI can be one of either complete dystopia, like it's a nightmare, and you'll see people
Yeah.
push back against it. This is a terrible, threatening thing, versus an overly optimistic. This is going to be the best thing for humanity ever. And in fact, there's a much messier middle ground where the reality is, look, people are already using these tools across the board. Yes, they're deriving benefits in some scenarios. In other ways, there's going to be harms. The fact of the matter is, this is going to be an ongoing conversation and a very messy one. So, which is also why it's nice to talk to you about it, because it's complicated. Um, Progress is never linear. No
Yeah.
innovation in history has ever solved all problems while not inviting new ones. And in this case, we've got very serious considerations to think about. So I don't see these conversations going away.
Okay. And as this is my last question, but I have this thing that what I mean, there should be some starting point, right? There should be a starting point. So what according to you in terms of ethics, regulations, and most importantly, in terms of culture, because we live in a world where every culture is different, and even in the same cultures, there is so much disparity. So, what is that starting point that where we as humans start to be collaborative instead of being competitive, starts to be more accepting rather than being more repulsive? Because you mentioned in the podcast, which is a very valid point, that artificial intelligence is going to create new types of jobs. Yes, the current jobs will be replaced, but new jobs will be created. It's the adaptation that has to happen. So, where do we start with that thing, and especially in a field like medicine?
I think we've got to start with education and training, and it has to be embedded in the at the earliest stages. And we've got to be very honest about the fact people are using these tools. Younger people in particular tend to be faster adopters of these tools. So what does tend to happen in education, and particularly something like medical education, which you're learning very much from people who are more senior and who are older than you. A large part of it's like an apprenticeship almost. You're learning from your superiors, particularly on the job in hospitals and in clinics. And that then tends to mean, in this case, that there's more of a lethargic attitude towards technology because older, in this case, doctors haven't used these tools.
Yeah,
So we've really got to have and it's been delayed, I think, for too long, particularly in medicine. But we've got to have a much more candid conversation about the fact that doctors are using these tools. How do they use them in ways that are more effective, and
yeah,
that reduce the risk of harm? And it could be just very targeted guidance, but it needs to be inserted in curricula. And it needs to also to happen in our primary schools, our secondary
yeah,
schools. We need to just have a broader conversation around the use of AI, and its consequences. Um, because yes, I do believe these tools they're only going to get better and better, and we
yeah,
need to talk about what they're going to do to changing employment opportunities, and what on the societal level the risks may be of these tools,
yeah.
because we need to hold our politicians to account as well, um,
True.
and how they're going to change the societies that we live in.
Yeah. I mean, I have read your book, and honestly, this book challenged my own views because I always used to think, and I'm always in a dilemma that how does my career looks like? Because if AI is going to take over everything, what will I do as a researcher, or what will I do in my field? But your book actually changed my perspective about, okay, it's not going to take my job. It's maybe going to partner with me, maybe an assistant with me, and I have to be more accepting of the fact that I don't know everything. So yes, I take the help of AI.
Oh, that's
And
interesting.
earlier I used to also, just when I used to code, and I was very skeptical, or somebody should not see me using artificial intelligence or Claude or any bot that I was using at that time, that they might think that I don't know it. But the fact is, yes, I don't know it, but I'm trying to learn it.
Yes.
So I think,
That's really interesting to hear. And yes, these tools can be very empowering for people as well.
yeah,
Um, and people ultimately just, if they have, even if, take it back to being a patient, people just want to know more about their own health. They want to use
yeah,
tools that are going to be useful to them. And we saw it with Google, we're seeing it with AI. It's the convenience of these tools as well. Um, yeah, but it's fascinating to get your take on it as well.
yeah. I mean, it's because of people like you who are actually taking on the field. We realize that, okay, we are not, we are in the middle of something that is taking on a revolution, but if you adapt to it, you're going to survive it. You're going to survive the thing over there.
Yeah, but ultimately, I think the tools will get better and better, and we're going to have a continuing fluctuation in society and our relationship with technology. So, um, we may be having more conversations about this in the future.
Would love to. Would definitely. I mean, it's always nice to have your brain open to both the kinds of possibilities, good and bad, and then take the next step. For example, patients should always know that they can use AI and they cannot use AI. So it's their choice to use it or to not use it, or to believe it or not to believe it. So I think it's always open to them, right? Like
I
humans, like
think
what they
so.
want to have.
Yeah, and ultimately they're going to use it. I think so. We need to get the guardrails in, and we also
Yeah.
need to give guidance,
Yeah.
um, because we want people to get benefits.
Yeah, and exactly as you mentioned in the podcast, which is a very nice point, that when people are using AI, they need to be very careful while they are using it. They need to not believe everything, because even the bots, when you give we give our report, says that this is based on the facts and you should not trust everything that we say. Even on the chat GPT, this is very funny, but on the down they write it that for important information you should go to the net and browse and not believe everything that we say. So technically they
Exactly.
come with a warning
Yeah, and
themselves.
we need more of those uh, very targeted guidance at different
Yeah.
populations, but advising people how best to use these tools to benefit them, and when they are going to be quite
Yes.
risky.
Yes, definitely. And I would
Well,
like to
thank you
really
very
thank
much
you
for
for
the
joining the
conversation.
podcast, because it was really nice talking to you. And it was a technically fan moment for me, because
Likewise.
reading your book and then talking to
Oh,
you
that's
is
right.
something like, okay, I read her book and now I get to talk to her. So it
Oh no,
was
my pleasure.
really
It's
fun.
been such a nice
So
conversation, and really, I liked the questions. It was a lot of fun for me.